We, a group of professionals, offer a strategy that has the optimal use of geographical information system and spatial decision support system in COVID-19 vaccine rollover in New Zealand. The concept is using geography as the linking factor between components of the health system for immunisation services planning, monitoring and evaluation. This is not a magic or noble technique, but a way to help our leaders to fight the pandemic. Our project aims to support the existing system rather than replacing it. We believe that New Zealand, and at this stage of the pandemic, is one of the very few countries that would benefit a lot from the system. Because we have almost no natural herd immunity, therefore our protection from the virus will be completely reliant on the vaccine. Our project started on December 2020, offered to different authorities since February 2021, but we have yet to receive a reply. However, we believe that it's better late than never. This is an attempt to spread our message across to the right people on time. We have no potential conflict of interest. Rather, this is a gift to the New Zealanders who shared their land with us as professional immigrants. Distributing COVID-19 vaccines on a massive scale is a complicated task, as it involves strict sub-zero storage requirements, timely delivery, effective communication between authorities and the public, and prioritising of vulnerable groups while ensuring equity across regions and communities. By using geography as the connecting element, the multi-sectorial data integration supported by Geographical Information System (GIS) and Spatial Decision Support System (SDSS), we have 6 main aims in our proposal: identifying, maximizing, ensuring, assuring, forecasting, and retaining. We will discuss and explain in depth these aims and how they could be achieved while we go through the next slides. Our first aim is identifying gaps in vaccines access and formulate alternative distribution options. This is the main factor that could maximize the vaccination coverage rates and hence stronger herd immunity. Our third aim is ensuring equitable access. This is a critical part of the vaccine rollover policy made by the New Zealand Health Ministry. Among the different groups, either medical or non-medical, and different ethnicities, it is important that we assure transparency and rising public awareness, as this will reassure New Zealanders and hence cause less conflicts with the policymakers. Forecasting the prognostic factors for the rapid spread of COVID-19 will ultimately help the leaders make the right decisions on the correct terms. Towards the end of the project, the retained data will be of great value for future purposes. Even though New Zealanders have experienced some pandemics in the most recent past, some people and media outlets still doubt whether COVID is real, questioning the validity of the evidence shown. We are not immunized against these pandemics, especially the viral ones, and there will be more in the future, which could be more fatal. Therefore, we have to be prepared at any given time. Nonetheless, a good percentage of people, even the educated ones, and people on high-risk front lines, still do not believe in vaccines in general, and on COVID-19 ones specifically. We need to know who they are and where they are located. Unfortunately, these misbeliefs have created a huge pressure on the policymakers, especially when related to economics and freedom of travel. Before I continue, it is important to admit that we aren't epidemiologists. With that in mind, everything in this project depends on facts and includes our personal bias. As Dr. William Edwards Deming once said, without data, you're just another person with an opinion. At the time of this presentation, more than 175 million people around the globe have been infected by the deadly virus. Among the international percentage of population who are fully vaccinated by country, New Zealand is below the world average. Having only established its program in February of this year, that is nearly 2 months after the UK did. Unlike most vaccines that target children, these vaccines will target adults, a larger and more difficult population to target effectively. But when will our children be considered for vaccination? In addition, different SARS-CoV-2 vaccines may have different requirements for storage and delivery, and procuring highly specialized equipment may be necessary. However, our vaccination rollover strategy can be applicable in New Zealand because of these key facts. New Zealand had very few active COVID-19 community cases, and therefore the impact of vaccination in achieving herd immunity is huge. Our health system is not fatigued, and vaccine saves lives. Although we have a small population of 4.7 million, the population is widespread and lives over a large land. We have 20 district health boards and around 40 public hospitals, which are related to the geographical boundaries of the 20 regions. These 20 regions in New Zealand are reflected by the performance of the functions of regional councils. Furthermore, New Zealand can be subdivided into two large states, with 30% of the population at the South Island and 70% at the North Island. Kiwis are well educated and they follow instructions. In addition, New Zealand has a well-established database registration and a reliable census system. Over 85% of Kiwis have internet access, and around 92% in occupied private dwellings had access to a cell or mobile phone. Our country has one of the firmest security systems, and we should also consider the appreciated function of civil defence in New Zealand and its role in epidemics. On the other hand, our beloved Māori brothers and sisters are at high risk. As statistics have shown, Māori have been disproportionately affected by past pandemics and experience higher rates of infectious diseases than other New Zealanders. Māori generally have higher rates of chronic conditions and comorbidities, hence higher risk of hospitalization and fatality. Furthermore, in Aotearoa, New Zealand, it has been estimated that COVID-19 infection fatality rates could be 2.5 times higher for Māori than New Zealand Europeans, and 2 times higher for Pacific people. Additionally, the unequal distribution and exposure to the determinants of health further increases the risk for Māori. Health inequities between Māori and non-Māori are unjust, large, persistent, and occur across the life course. Moreover, family wealth and geography are major factors determining childhood vaccination rates around New Zealand. Although GP clinics appear to provide better access to the total population, over a quarter of the approximately 30,000 people who live 30 or more minutes from a clinic are Māori. Let us look at the New Zealand data about national immunisation coverage, which is done by the Immunisation Advisory Centre at the University of Auckland. The percentage of fully immunised at 6 months of age from June 2009 to June 2018. It peaks at 82% on December 2015 and reached the lowest point at 77% on June 2018. However, when looking at those immunised at age 5, the national percentage goes up to 87% in 2018. Unlike the previous graph, this one shows the percentage fully immunised at 5 years of age by ethnicity. Dark blue represents New Zealand European, purple represents Asian, green Pacific, red Māori, which went up from 65% to 85% over the period of 8 years, and light blue is other. Moreover, looking at the percentage fully immunised at 5 years of age by deprivation, it shows the overall percentage of vaccinated is down to less than 90% for all the groups, including Māori. This geographic graph shows the percentage of Māori by total population. So the most important question now is how can we convert the previous data to the geographic ones? i.e., how can we locate the subgroups who aren't vaccinated and therefore help increase their access to the vaccines? Because this is the first time that New Zealand is trying to vaccinate its entire population, it has brought up some obstacles. The country only has data relating to vaccines with children, however, not with adults. Although it is essential to have the statistics about the COVID-19 epidemiology in New Zealand, it is not enough as it lacks the geographical part of data. These datasets show the number of COVID cases by age and cases by ethnicity. However, one of the questions we could answer is where are these cases and how do we target them? Classical data is not enough. We need a system that allows us to look at data from a different perspective, giving us a more practical set of data. We need data that answers our questions and provides us with ideal solutions. Geographical Information System, or GIS, allows us to view and understand the spatial patterns and relationships between different datasets using a range of tools and present that in different ways to different stakeholders. The graph here shows the vaccination rate by the 4th of April 2021. The role of geography as a unifying dimension between different sources of information and the use of geospatial technologies as tools to collect, manage, visualize, and analyze geographic data is crucial to support evidence-based decision-making across the whole immunization cycle. Moreover, it provides information from both sides of the coin. The causes for the health issue cannot be fully understood without exploring the spatial interplay between the underlying social, environmental, and infrastructural factors. In short, understanding the where helps us understand the why. We believe that GIS is the ideal system to use. In the last decade, there has been an increased uptake of GIS in immunization programs, in concomitance with an exponential increase in the availability of georeference data, GIS software solutions, and tools for geospatial data collection, management, and sharing. Consequently, the number of immunization studies and publications reporting the use of GIS has increased steadily from the mid-2000s. A GIS is an integrated collection of computer software and data needed to view and manage information about geographic places, analyze spatial relationships, and model spatial processes. A GIS provides a framework for gathering and organizing spatial data and related information so that it can be displayed and analyzed. GIS allows for the integration of data from many sources using geography as a unifying element, including but not limited to population and health surveys, routine health information systems, census data, environmental and infrastructure data. It therefore offers the opportunity to combine data sources, providing a deeper insight of the context in which vaccination rollover programs operate, capturing patterns and outcomes and their association with socio-economic, political, and environmental factors, as well as identifying areas of high priority for investment and interventions. GIS provides means to integrate various temporal and spatial data related to logistics and demographics that can provide insight, analyze planning scenarios, and assist in the optimized distribution of the vaccination. COVID data has a geographic context and therefore can be linked with their related location data. Data stored in a GIS are not simply maps, but rather datasets that combine geographic entities with attributes. The ability of geospatial technologies to relate different aspects of the immunization program with the surrounding environment through geography lies in the method used to analyze the information stored in different geospatial layers presenting the same geographic extent. A GIS can query, combine, and analyze these different layers using the relative location of the objects contained in each of them. The immunization program collects statistical data and information that can be attached to a specific geographic object through the use of a unique identifier. Such information or statistics, referred to as attributes, include, for example, the number of vaccine doses delivered at a facility or the population count of a community or settlement. GIS also ensures better accountability, improved coverage, and efficient investment of resources with minimum waste. It conducts spatial analysis to explore spatial relationships between geographic objects and entities, such as distance, contiguity, overlap, intersection, etc. The existence of spatial patterns and trends of a variable using spatial statistics, or assess the level of spatial correlation between multiple variables. For example, is immunization coverage particularly low in several adjacent geographic areas of a country, and do those correspond to areas with low density of vaccination services? Another important example of the statistical attributes is the vaccination coverage over a specific area. The composite of attribute and geospatial is referred to as geographic data and represents the way through such attributes are becoming available for spatial management, visualisation, and analysis. Assisting in identifying missed populations. In the case of immunization programs, such capacity allows, for instance, to explore whether a cluster of settlements is nearby or far from a health facility, or whether a specific region with low immunization coverage is co-located with an area with fewer immunization delivery sites. In addition, GIS allows remote and isolated communities, frequently missed by vaccination activities, to be made visible and adequately accounted for during planning. The opportunity provided by GIS to linking immunization system analysis with other components of health, infrastructure, and environmental systems, using geography as the connecting element. Such integration can provide deeper insights into the barriers and factors limiting the access to immunization services. We should also remember that periodic COVID data has a geographic context as well, allowing a more comprehensive identification of gaps in immunization systems and more holistic intervention approaches. We can also apply SDSS, Spatial Decision Support System, at any stage of the vaccination rollover. SDSS is interactive computer systems designed to support a user or a group of users in achieving a higher effectiveness of decision-making while solving a semi-structured spatial decision problem. While having an explicit geographic component, it supports rather than replaces the user's decision-making skills. It facilitates the use of data, models, and structured decision and processes in decision-making. To summarize the vaccine rollover using GIS and SDSS, related data is collected and analyzed periodically. With the help of expertise and SDSS application if required, the relevant knowledge is applied and the feedback is given so that the cycle may be improved. Let us look at the common challenges for sustainable integration of GIS before we start the proposal, i.e., find out if the proposal is applicable in New Zealand or not. These challenges include needing resources to scale up regions to national level mapping projects, which are frequently a one-off. Maintenance and update of geospatial data, maps, and satellite and aerial imagery is needed as well. Definition of ownership and licensing of geospatial data and maps and appropriate use is not always straightforward. Field workers lack capacity and literacy to operate of geospatial data collection tools. Training and building capacity of community health workers might take some time, and the workload of health workers might not allow them time for local level mapping. The restriction of access to areas with security or political issues can hinder the acquisition of geospatial data. It's difficult to establish unique electronic identification and nomenclature of health resources for interoperability between geocoded health facility master lists and other geocoded registers. In addition, there may be political challenges. It is possible that there may be a lack of capacity and expertise to absorb, interpret, and use spatially modeled surfaces at the programmatic level, understanding information uncertainties and limitations. The lack of experience in the use of modeled surfaces at programmatic levels, and the need to understand the appropriate scale at which such products can be used, for example, regional, district, facility catchment level. A lack of trust and comfort in the spatiality modeled surfaces by national and local level health workforce, and uncertainty about value added of spatially modeled surfaces at programmatic level, all can cause problems. Further challenges include academic to programmatic gaps between academic studies and programmatic level application of such products, insufficient temporal interval of availability of spatial products based on census and surveys, outdated or unreliable census data, extended time lag between survey data acquisition and availability of products for decision making, as well as difficulty in providing micro-level insights with spatially modeled surfaces. It is also necessary to look at the whole theory of change to consider determinants of coverage in a holistic approach by integrating multiple data sources, i.e., geographic access is not the only barrier to seeking care. Limitations due to seasonality and temporal changes, for example, of population dynamics of vaccine stocks versus stationary analysis, and the sustainability of use of spatial approaches at programmatic level may also cause some challenges. There is also uncertainty about value added and relevance of outcomes of spatial analysis at programmatic level. There is a need to accelerate adoption of spatial approaches at country level, and there's also the issue of capacity and resources needed for gathering and processing the large amount of input spatial data needed for countrywide spatial accessibility analysis and modeling. The project will also pose as a challenge, as exact costs will depend on the approach, government-led with capacity building or not, the size of country, terrain, and season. Examples from district and national level mapping in Rwanda, Liberia, Niger, and Sierra Leone presented indicated costs between $8,000 to $30,000 USD per district when government and local workforce is engaged in the mapping effort. Despite all the challenges and cost, we still believe that the application of GIS in vaccination rollover is applicable in New Zealand. Our vaccination campaign aims to cooperate with different groups and organisations, making sure it is very organised and easy to understand. We plan to complete the campaign in 5 stages, hoping to impress the world with our achievement and success. We hope to determine a better future for all, and we hope to complete it in a targeted 19 weeks. Our 7 concepts include having exceptional teamwork, making sure that each stage is dependent on detailed data input. Our most crucial is the use of SDSS at each stage, and making sure that the stages are intertwined with each other. In addition, we have designed according to the needs of decision makers, criterion comparison, and alternative possible solution to our problems based on criterion. We hope to include a committee of high level of expertise, including public health clinicians, statisticians, vaccine steering groups, and social workers. We hope to minimize the time lag between the acquisition of survey data they derive from and the availability for decision making, to reduce the lack of in-country capacity and expertise to absorb, interpret, and use such spatial products, including the ability to understand the information contained in them, as well as their uncertainties and limitations. It is also suggested that a successful strategy to improve government engagement and reduce investment from external partners is to pursue partnerships between government and other local stakeholders, including universities, national statistic offices, and the private sector. We also hope to add third-party observing committees, assessment of performance, monitoring, and follow-up. Studies show that effective collaboration of stakeholders, including different government departments, universities, and national statistics offices, was highlighted as a factor of success in several countries. The secrets to success includes good leadership, exceptional teamwork, public awareness, and most importantly, related data input. A complete listing and up-to-date registry of data is a crucial component of the planning. More importantly, the data integration from various sources related to immunization. The challenge is with the sustainability of the integration of such spatial techniques at the programmatic level, the significant capacity and time required for gathering and processing the large amount of input spatial data needed, and the need to account for the seasonality and dynamics of health and human systems, for example, of population migration and vaccine stocks, in the spatial analysis. We have chosen to take UNICEF's approach, which has been successful in using GIS with other vaccinations. It includes determining current coverage of target population, mapping immunization resources and key features, identifying barriers and determinants to access and utilization, planning intervention, and monitoring implementation and evaluating impact on health outcome. We recommend the New Zealand government to learn from the experience in some other countries, such as Cameroon, Indonesia, and Rwanda, to explore the country-specific successes, strategies, and challenges in the integration of GIS in immunization programs. Like most new applications, there is a lot of promise, but also a lot of pitfalls that must be avoided along the way, hoping that the benefits outweigh the risks and the costs associated with this emerging application area for modern GIS techniques. Next, we then need to define the main attributes attached to existing geographic objects related to immunization programs. We need to identify health facilities, vaccine storage facilities, and administrative divisions. Tracking who received which vaccine and when will be a major data undertaking. It will let us know the available vaccine doses and doses given over the past month, the number of communities and settlements part of the health facility catchment area, stocks, available volume, number of refrigerators, and type of electricity supply, as well as immunization coverage from extended program on immunization surveys aggregated to administrative divisions, population count from census, and the count of health facilities. Now we will go through the 5 stages of our suggested COVID-19 vaccination rollover in more detail. The first stage, which includes locating vaccine storage units and raising public awareness. Our strategy doesn't interfere with the current government plan, rather it will increase its success. We highly recommend keeping the international borders closed to foreigners until the whole vaccination campaign finishes. We strongly support the lockdown protocols that already exist. In addition, we also support their vaccination rollout scenarios. Although we were unable to reach the health authorities at early stages, however, we still believe it's crucial to use GIS in the very soon coming stage, where almost 90% of the population will need to be vaccinated. By looking at the illustration of volumes and timing of vaccination rollout planned by the Ministry of Health, it's easy to see that there is a lot of work that needs to be done. Using GIS will be of significant value. We are trying to invest time to save time. Back to the first stage of our plan, we recommend that vaccine rollover should depend mainly on two factors: population type and density, as well as the district health board system. Further, if the current vaccine distribution plan provides doses not based on state population or based on the number of health workers who will provide vaccinations, it will mean that some states could have a surplus of vaccines while others have a deficit. Furthermore, the government must meet Te Tiriti o Waitangi obligations, work in partnership with Māori, and engage effectively with other communities. Frameworks such as He Pikinga Wairoa can support the assurance of tino rangitiratanga over the design of program delivery and the safe and effective provision of vaccines. We recommend that in each district health board, a GIS office is implemented in order to decrease the workload and increase productivity at the micro level. In addition, decision makers and program managers at every level will be able to review data and take appropriate actions. Having real-time data is also hugely motivational for government staff and partners and increased efficiencies. It is equally important to establish communication protocols for managing information. Supervisors at the district health board and village levels should participate in daily team meetings to discuss how the day went, check stock status, and track progress against targets. Whereas supervisors at the National GI Centre will have access to a supervisory dashboard that they could use to quickly identify necessary interventions. At the national level, a call centre should be established to provide feedback to districts and supervisors when errors or low coverage were noted, as well as seek guidance and provide updates on follow-up actions. The function of GIS is based on a database which may be used by different users in order to meet various information needs. GIS integrates software and hardware to digitally capture, manage, analyze, and visualize geographically referenced data. The database consists of a series of information layers, which refer to the same geographical area. Each of these layers contains data that applies to the geographical facets of various aspects of the vaccination campaign, such as population demographics, potential storages, delivery centers, weather forecasting data, and much more. All these must be well integrated in order to improve the identification of populations in need and the vaccination burden, as well as their variability at subnational and subdistrict levels. There are two ways of hosting data. The first, manually uploading your vector and raster data directly to your GIS cloud account, and the second is making changes in your existing data. Create new, author, and share your data and maps in Map Editor. Users can easily capture digital data in a GIS. If the data is not digital, then users will need to employ various techniques to capture the data, such as digitizing maps by hand tracing with a computer mouse, utilizing a digitizing tablet to collect feature coordinates, using electronic scanners, or uploading Global Positioning System GPS coordinates. We then need to map our immunization resources and look at the key features regarding this matter. This includes establishing geocoded registries of health facilities and community health workers, as well as identifying amenities capable of storing and dispensing the vaccine. In addition, district health boards should implement surveying their facilities to know where their sub-80 Celsius freezers should be. This could be at large hospitals, scientific research facilities, and some large pharmacies. GIS is a powerful decision-making tool which can help improve locating the vaccine storage sites. For example, it can identify the service delivery locations that provide maximum accessibility of a given population based on numerous factors such as population density, employment density, available roads and public transit options, and many others. It can also help identify the number of people living in a specific region who are more than half an hour away from district health board facilities and the healthcare service delivery locations. In addition, it can help identify the best routes using roads and public transit between both population centres and rural areas to access existing healthcare service delivery locations. It can also help assess current services and evaluate whether they are meeting the objectives of the vaccination campaign, considering the effect on resources for proposed interventions and assessing their cost effectiveness, as well as supporting decision-making in any necessary changes. To support the identification of inequities in immunisation coverage and to make remote and isolated communities and settlements frequently missed by vaccination activities identified and accounted for, we will use satellite and drone imagery to map settlements, towns, villages, hamlets, delineate facilities, catchment areas, and geographic features such as lakes, rivers, forests, and mountain when needed. It is also a powerful tool for compelling advocacy on the allocation of funding and resources. This vaccine uses technology called a messenger RNA platform, which uses the genetic material of COVID-19 to invoke an immune response. The vaccine leads the pack because it is the quickest to manufacture. But speed of manufacture is offset by complicated delivery. Pfizer's vaccine needs to be stored at an unprecedented -70 degrees Celsius or -94 degrees Fahrenheit, a temperature met only with the coldest deep freezers. GIS applications will be used to track stockpile shipments in real time. The clock starts well before we actually receive the product. So when we receive the shipment of vaccines, we should know exactly where they are going to be stored and who needs them. Pharmacies do not have freezers this cold because no approved drug has ever needed to be held at this temperature. Only large medical centers, universities, and perhaps some public health departments will probably have such deep freezers. We suggest 4 main national stores. This is mainly because these 4 cities, Auckland, Wellington, Christchurch, and Dunedin, have the proper facilities for mass storage and are geographically distributed across Aotearoa. The new application would have to give an efficient way to manage a sudden influx of supplies, aid in deciding where and how much to distribute to local receiving agencies, and track distribution. Then the 4 main national stores will distribute vaccines to the first-line provincial stores in the cities highlighted in green. By using the national commercial flights, the distribution to the provincial stores can be facilitated easily and time-effectively. Dry ice is considered a hazardous material, so it must be transported quickly, posing potentially serious challenges for rural areas where several days of vaccine viability could be lost in transit. These provincial stores can well distribute vaccines to the second-line local stores, which will increase availability of vaccines and reduce logistics costs. Dispensing vaccines to the vaccination centres can be done directly through the second-line stores or through the first-line stores when mass vaccinations are required. Healthcare workers will need to take out an appropriate amount of vaccine a day, meaning carefully calibrating between taking out too little and risk sending patients home, and taking out too much and risk wasting very limited doses. The islands included in the New Zealand COVID-19 campaign should have their own second-line stores, which will receive their supplies directly from the Auckland National Store. Now we need to locate the vaccination centres, depending on the previous factors we mentioned, using GIS multi-layer mapping. The spatial decision support system can be of significant use during this stage. This will include places of employment, pop-up clinics, and usual vaccination services, such as Māori and Pacific providers, GP clinics, which counts the majority, and community pharmacies. We should also take into account those with limited access to medical facilities in New Zealand. A 2004 study shows that about 2.5% of the population in New Zealand lives more than 30 minutes from their local GP. To make matters worse, around 16% of the New Zealand population does not have timely emergency medical service access to advanced level hospital care via road or air, and more Indigenous, Māori and older adults have poorer emergency medical service access, according to a 2019 study. The northern and southern parts of New Zealand have high average travel times to hospital services. Moreover, more than a quarter of the approximately 30,000 people who live 30 or more minutes from a clinic are Māori, according to an article published last month by the New Zealand Medical Journal on the 21st of May. As you can see from this graph, it shows that there is a high population of Māori in the North Island, where these two graphs show that the Pacific population and those aged 65 or over are scattered across New Zealand. These maps show the travel time to 5 types of potential vaccine delivery sites: stadiums, community-based assessment centres, GP clinics, community pharmacies, and schools. The results suggest that delivery through schools would provide vaccine access within 30 minutes to almost all of the population, and that this would be equitable. However, there would likely be logistical challenges involved in delivering COVID-19 vaccines to the general public through all schools. However, of the people affected by travel burdens under scenarios of vaccine delivery via GP clinics or community pharmacies, more than half live in areas of high socio-economic deprivation, while less than 10% live in the wealthiest areas of the country. In order to map precise location of vaccination services with respect to the location of population in need of vaccination and the geographic barriers between them to better match supply and demand, there are a few things we need to do. We need to identify impact of distance and travel time to services on access, utilization or coverage, map accessibility to vaccination services based on realistic travel times, accounting for terrain, natural barriers, and a typical mode of transports. And finally, identify determinants of inequities in service delivery, utilization, or coverage by spatial overlap with population socio-economic disadvantage and accessibility. This is how the GIS map should look like. When we have to suspend visitation in one centre, such as if new cases of COVID-19 occur in a facility, the GIS should be able to locate the closest available centre to cover this new demand. We can determine optimal delivery channels based on distance and distribution centre utilisation by visualising sub-national or sub-district inequities in vaccination coverage and service utilisation. Let us take a look at a graph analysing the impact of opening or closing distribution centres in Spain. GIS can help a local health department to do a few things. It can help determine who is treated, geocode patient information, determine who needs to be treated, spatial join with population information, calculate vaccination rates, and notify those who need to be treated by activating automated telephone reminders in low vaccination rate areas. Identifying the best route channels is extremely important for rural areas and during extreme weather changes, which we should expect to happen during wintertime. Our system could minimize delivery costs and ensure efficient and equitable access to vaccines. We can do this by identifying gaps in access and formulate alternative distribution options. Based on the International Vaccine Access Centre's recent study on childhood immunisation programme costing, delivery costs account for nearly half of the total immunisation programme costs. Globally, delivery cost varies across regions, ranging from 18 cents to $11.31 per dose delivered, depending on accessibility and country's infrastructure. It also prevents clashes between the different authorities. We need to have an efficient tracking system. According to the New Zealand media, it appears that there was a lack of even distribution of the flu vaccine last year. It is important to make sure that we have vaccines in the right quantity and in the right place, plan routes based on real-time and historical data, track the real-time vehicle locations and delivery status, identify the geographical areas that have access over a 60-minute drive, and prepare for poor weather. It is important that we build trust, as people's willingness will be affected by what is said, the way it is said, and who says it in the months to come. High uptake of COVID-19 vaccines among prioritised groups should also not be assumed. It is important that we raise public awareness. Locating the areas which have low vaccination rates can help us identify whether to use social media, schools, religious centres, or whānaus to help encourage people to take the vaccine. One of the biggest hurdles any vaccination campaign will face is gaining public trust, including among healthcare workers who will be asked to take the vaccine first. This is our best way out of this pandemic, so we want to recommend and encourage our community members to take the vaccine. What would be the worst is if a vaccine that's safe, effective, well distributed, and able to be given to anyone is just not taken. Although the Ministry of Health must submit the data on its vaccine to the MedSafe administration for approval, another important step will be following the publication in an independent, peer-reviewed scientific journal and continued transparency about its safety and effectiveness. Providing accurate information about both risks and benefits is crucial to maintaining trust, and time is very important. The role of social workers and community leaders is crucial as well. A good example is that during the first lockdown in New Zealand last year, high rates of influenza vaccination were achieved for Māori in several district health board regions, attributed to an approach led by Māori and iwi organisations. The opposition party should play a major role as well. This is the right time to prove their promises to the population. Now onto the second stage of our plan, vaccine distribution and data collection. The chart shows the count of vaccinations administered on a given day from the COVID-19 immunisation register by the 18th of April this year. Note that some records are entered in the register at a later date than the immunisation was received. This means that the figures for a given date may move for some time after that date. For us, it means that there is a gap in the system, since daily vaccination rate should be rising steadily. Although the Ministry of Health has anticipated that there could be a potential variance of plus or minus 10% between district health boards and actual vaccination numbers, as you can see on the left side chart, there are around 240,000, 56% of doses, that are stored and not given. This leads us to question, what is the distribution target of these? When and where? What is the cost of storage? What are the expiry dates? When is the next vaccine ship arriving? And where is it going to be stored? It is also important to note that the usage of vaccination stock by the 18th of the 5th, 2021 was 98%. Is that because they stopped importing, or do they have a proper distribution system? The rollout costs for vaccines not only include labour, cold chain storage, transportation, capital, and other recurrent costs including program management, training, social mobilization, waste management, and monitoring and evaluation. This obviously will also delay the deadline time of the campaign. Booking in advance is essential, as it will avoid the delay in transportation during rush hours, reduce the load on GPs, and gives more time for any side effects to appear, and so that patients can be managed during the daytime. The targeted time of using a single vaccine is 36 to 48 hours. When people book in advance, they are 3 times more likely to follow through with their vaccination. Vaccines administration should only be allowed between 9:30 and 3 on weekdays and 8 to 4 on weekends. There are also a few questions we have to ask ourselves, such as, what is the best amount of vaccine packs to be assigned to each vaccine centre to minimise vaccine degradation? What is the best number of staff required for vaccination in each vaccine centre to minimise service waiting time? This will include looking into the number of health workers deployed and the average health worker workload. And finally, how many people have no contact address or GP registration? It can also tell us about stock and vaccine wastage, the number of doses used, issued, discarded, and reason for discussion, such as partial use, contamination, vaccine viral monitor color change, and other factors, and the vaccine wastage rate. Considering mass vaccination could maximize the number of shots in a short period of time. GIS will answer the question of where or when or how big those sites are going to be. It can also help people with providing up-to-date wait time information, which would therefore help people self-distribute among the different vaccination centres. It will also regulate occupancies among the vaccination centres and provide better social distancing, less impaction, and people getting through much quicker. Those doses will need to be meted out because potentially flu-like side effects from the virus could sideline some. For that reason, a hospital could not vaccinate its entire intensive care unit at once. If you have a staff of 5,000 you have to vaccinate, it's not going to be easy to find the staff to do that. However, mega sites need a lot of personnel. Only 10% of workers would actually be administrating vaccines. The rest would be managers, personnel screening recipients, paramedics, security, potentially translators, some emergency personnel, and IT support. Mass vaccination could pose problems of access and equity and develop new packaging to preserve temperature-sensitive products for transport. For example, this is a GIS dashboard for a mass immunization campaign from the National Command Center in the World Health Organization of Uganda in 2019. To our knowledge, there are 4 different types of the vaccine. And LabPlus already has an incredibly good drug distribution tracking system. However, it is only one-way tracking. The world needs multiple vaccines to be approved to even begin to meet demand, and approving multiple vaccines adds to the complexity of the delivery effort. Healthcare providers will need to track who received which vaccine and when to ensure people are protected. We should digitize registration activities. The use of mobile phones, laptops, or tablets with geo-navigation systems allow for an entirely new level of monitoring by enabling real-time tracking of immunization staff during campaign activities, regular outreach, or supervisory visits. Examples of softwares used by the World Health Organization include DHIS2 District Health Information, Software 2, ODK Open Data Kit, Survey 123 for ArcGIS, Vaccine Tracking System VTrack-S, and Zijiba Digital. Interpersonal communication is very effective. Digitized registration data that includes phone numbers can be used to reach households with reminders from local influencers. Robocalls can reach local communities through pre-recorded messages from lady health workers and community leaders. Because we are vaccinating the majority of the population in New Zealand, we should take advantage of having more data about the health background of people. Therefore, this could be the first, most extensive national health survey ever done in New Zealand. So, for example, by adding smoking and whether people have chronic diseases, will be hugely beneficial for future use, as we will explain later on. GIS allows the users to view, understand, manipulate, and visualize data to reveal relationships and patterns that solve problems. The users can then present the data in easily understood and disseminated forms, such as maps, reports, or charts. By allowing near real-time monitoring of vaccination activities, GIS also ensures better accountability, improved vaccine coverage, and efficient investment of resources with minimum waste. The real-time, same-day element should be prioritized during platform design. The primary motivation for an RTM, real-time monitoring system, is to ensure prompt corrective action during campaigns. This means automating processes such as data cleaning, flagging areas for corrective action, identifying the actions needed, and confirming the actions to be taken. It also entails specifying information requirements, choosing user-friendly platforms, minimizing the data collection burden on field staff, and prioritizing timely communication and coordination across levels to clarify and address issues. Monitoring the movement and activities of teams, RTM strengthens coordination among partners. It can also be used to validate micro-plan maps. All that's needed to do is make sure that the data keeps flowing in. To use the dashboards, you just need to log into the system, look at spot maps, and tap on the maps to zoom in and identify problems. Information such as administrative units, vaccination posts, and targets should be available before the campaign begins, so dashboards can be developed and tested. GIS will make public forecasting much easier, providing daily updates, the location of vaccination centres, vaccine eligibility, and much more. Real-time monitoring will give you 24/7 visualisation and analysis, and therefore can recognise any problems that need to be solved immediately. It will give us information about vaccine availability, vaccination rates, clusters, and controlled outbreaks, as well as flu vaccinations in each community. Starting with vaccine availability, the real challenge to COVID-19 vaccination rates isn't only hesitancy, it's equal access for all groups, including Māori and Pacific people. The questions which can be easily answered by GIS are what populations would be served by a vaccination centre, and how reachable are candidate sites, and how would they supplement the existing locations. We need to dive in deeper and break down the demographics of each site, asking ourselves, will the vaccination program be targeted at areas with high case numbers, or rather focus on population characteristics such as the age distribution, population density, or economic conditions? It is important to know about vaccine availability. For example, it can tell us which rest homes would be assigned to which vaccination centres in order to fulfil the requirement that they are within a 40-minute drive. And therefore, this will mean more efficient allocation of resources relative to target population. One of the vaccine availability challenges easily solved by GIS is locating areas within a 30 and 60-minute public transport journey of selected hospitals. When it comes to areas of difficult access, we wonder if it would be easier to target them with mobile teams. Achieving equitable immunisation necessarily involves balancing the logistical constraints of distributing and administrating the time, as well as temperature-sensitive COVID-19 vaccine, with minimisation of the barriers for those who wish to receive it. An example of what the GIS system could do is identifying where there is greater vaccine demand. Considering the potential of new GIS technologies, such as high-resolution satellite imagery feature extraction, drones, mobile phones, geotagging, and nighttime light satellite images, can address limitations associated with outdated or unreliable census data, limitations in access to remote areas or security-restricted areas, and accounts for population movements which are not captured by spatially modeled surfaces. It is important that we prioritize areas and follow-up activities for regional action to prevent the disease from spreading. In addition, as the program progresses, it might be possible to open up new locations as vaccination centres. In cases of extreme weather changes, for example, we can build emergency health structures to relocate the vaccines for easier access and minimize wastage. In addition, the operational cost estimates can also be added. Significant savings in fuel, fleet size, and time can be achieved, as well as less logistical resources required. 24/7 geographical visualisation and analysis can also tell us about vaccination rates and provide data for estimation of population denominators and immunisation coverage. This can help us identify at-risk populations where some people may not have ready access to the vaccine or other people may choose not to vaccinate. Vaccine consumption data can be compared to coverage data to verify coverage. Red or green flags can then quickly indicate if targets were met or activities were of a certain quality. Infographic-style report for a potential location that summarizes data for an area of under-immunization around a candidate vaccine center can easily allocate extra educational facilities. In addition, vaccination rates can help us determine the best way to communicate with other partners and the public, for example, culture and community centers or religious groups. It can also help us detect spatio-temporal clusters of adverse reactions to vaccinations. A GIS platform will provide a valuable decision support system, not only to the planning stage, but also during the campaign, as it will allow the timely response to any changes, such as new outbreaks and the efficient sharing of data between involved parties. It can tell us about the location of close contacts, what is the variant of the COVID-19 and its location, and as well as identify the ideal way of testing delivery to detect how widespread the infection really is. For the health system to be adequately responsive, it should engage Māori and Pacific leadership in the governance, design, and delivery of vaccination campaigns. It will require resourcing, monitoring, and accountability to build adaptable solutions that ensure community aspirations are met. If vaccination rates are low, it would be useful to be aware of the factors which are stopping people from taking the vaccine and find out the best way to reach them. Essentially, targeted, community-based, specific outreach is needed for successful community vaccination campaigns. It would be much more effective if we had a geographic map, such as this one, which indicates different religions. This could help us speak to those communities and get their religious leaders to explain to them the importance of the vaccine. Moreover, having more geographic information about communities, such as deprivation index and their ethnic background will certainly help us achieve higher vaccination rates, as we will know who, where, and how to target. A good example is this dashboard showing areas requiring corrective action and reasons for low uptake. This dashboard from Malawi in its 2017 measles rubella campaign, where clusters were flagged as orange for requires corrective action and green for no corrective action. Automated decision rules and visuals like these streamline the process of data use. Nepal used a similar dashboard, which included an indicator called Action, which automatically calculates and flags which communities require follow-up. Color coding and mapping makes it easier to see which communities require action and where they are clustered. Along with the COVID-19 vaccine, it is very important to get the influenza vaccine as well, particularly during the winter season, when both influenza viruses and SARS-CoV-2 can infect people. Even if this is not scientific, the start of the flu season could confuse the health system and put more pressure on it. Reducing the number of people who get severe influenza and require hospitalization will also help ensure that the healthcare system, hospitals, and intensive care units will not be overwhelmed should there be an increase in COVID-19 cases. The flu vaccine should be offered in a wide range to the community with no restrictions. However, we should give priorities, and in addition, periodically match its map to the COVID-19 vaccine or COVID-19 PCR tests. All of the information should be open to the government security system and can be randomly and regularly checked for any illegal and privacy outbreaks. Any valuable data should be retained for the future. It is also important that we periodically check all of the vaccine's validity and reliability, not only through our national data, but also through the hugely valuable international data. Now onto the third stage of our plan, enhancing vaccination rate and enforcing the law when needed. Based on our research, we assume that the serious risks of COVID-19 could be low when vaccination rate reaches more than 95%, medium when between 80 and 94%, and high when less than 80%. It is also important to bear in mind that children, who make up about a fifth of our population, are not yet eligible to be vaccinated. That means that there will still be a low vaccination rate and herd immunity cannot be fully achieved. To support our view, according to the most recent Alberta government's health data in Canada, since the 1st of January 2021, 0.4% of people with one dose were diagnosed with COVID-19 14 days after the first immunization date, 0% of people with 2 doses were diagnosed with COVID-19 14 days after the second immunization date, 95.3% of cases were unvaccinated or diagnosed within 2 weeks from the first dose immunization date, 92.4% of hospitalized cases were unvaccinated or diagnosed within 2 weeks from the first dose immunization date, and finally, 86.8% of COVID-19 deaths were unvaccinated or diagnosed within 2 weeks from the first dose immunization date. One of the best ways to enhance the coverage rate is by identifying determinants of immunization coverage and inequities. Strong inequities are hidden behind global and national figures of vaccination coverage. These are associated with differences in urban and rural place of residence, wealth and education status, gender and remoteness. By finding out who, where and why, GIS could be of great significance. According to a study from Massey University, 76% of European New Zealanders and 81% of Asian and other ethnicities intend to get vaccinated. However, Māori at 64% have lower intentions to do so. There are many reasons listed for why individuals are interested or not interested in the vaccine. These include protecting themselves, avoiding getting seriously ill, protecting the community, needing more time for safety, side effects, and not liking needles. Now we can go in depth and diagnose the reasons for hesitancy. We need to be specific about the different barriers that stop people getting vaccinated and what can be done to remove them. By looking at landscape features, terrain, river, lakes, land cover, and etc., which constitute the environment that the population and the vaccine carrier will have to cross to reach a point of care, as well as the source of potential physical barriers to movement. Studies have shown that poor availability and access to immunization services are still the biggest barriers for vaccinations worldwide. We also need to ask ourselves, what kind of people don't turn up for the second dose of the vaccine, and do they prefer to have only one dose? Now we need to treat the reasons for hesitancy. Studies have shown that people trust doctors and nurses the most. As a result, we need to strengthen the voices of healthcare workers in presenting vaccination as a social norm. The social norms around us influence our choices, such as whether our friends, family, and colleagues are vaccinated. As a result, the vaccination level of a community might have a positive impact on the immunity of those nearby, more so than those farthest apart. An important thing people can do is urge their loved ones to get vaccinated. In addition, we also need to strengthen the voices of the influential members of the local community and those who have the social power. This can be done through preferred social media or impactful channels. Now that we know the who and the why, we need to know the where. We need to watch for misinformation distributed through social media. This then must be addressed promptly and aggressively. Using software such as EcoSec Pro for ArcGIS can filter social media for any geographic area stipulated by users. For example, in Pakistan, short videos by local community influencers were developed overnight based on information on communities refusing the vaccine that was gathered through WhatsApp groups. The videos were used by frontline polio staff and EPI social mobilizers through their mobile phones to convince refusal communities to vaccinate their children the next day. Evening vaccinations were offered in some refusal communities where fathers were decision makers, so fathers could be present and approve the vaccination. Additionally, Twitter text analysis data can be added to the GIS layers. This analysis data has previously been used and tells us whether people are hesitant, neutral, or advocating for the vaccine. Now that we know who, where, and why, targeting is key. By target messaging at local levels for the unique audience, using strategic communication, we can overcome vaccine hesitancy and anti-vaxxers. The main aim is to get the number of people saying yes to increase and lower the number of undecided and those who don't want to take the vaccine. This has already been achieved in some countries by using the right tools. We need to make timely decisions to extend the campaign for a period of time, when and where precisely needed, to help the campaign achieve its targets. By adding another 2 to 3 months to the vaccine campaign, we should be able to increase the vaccination rate to more acceptable levels. In a study from Massey University, the majority of New Zealanders support restrictions on people who refuse vaccination. Travel bans, restricted entry to public places, and restrictions on their children attending school are among the measures that find support. It shows that 28% of people are less willing to consider a higher tax rate and 30% reduced pay. Based on this data, we would suggest closing the borders of the high-risk regions for a period of time advised by experts until the vaccination rates reach a safe level. During this period, the different authorities and related personnel should work alongside each other around the clock to achieve the maximum vaccination rate in the shortest time frame possible. Should there be any new cases within these regions, the lockdown will be more restricted and focused to the high-risk regions rather than the whole population. Only goods can move between the regions, not people. Truck drivers, aircrafts, and ship crews need to be restricted with areas of stay in each region. We also need to establish an intensive public education throughout the media, using updated data and outcomes, and utilize the most advanced technology in this field. This will then be monitored over a period of 4 weeks, 2 incubation periods, and then the risks and the lockdown levels can be readjusted accordingly. Should our strategy be opposed, it is important to emphasize the following facts. This includes that only 38.7% of the recorded cases in New Zealand by the 11th of the 5th, 2020, which was 580 out of 1,497, belonged to known clusters, whereas the rest were sporadic. Secondly, the risk of death from the virus varies between 0.5% and 12% in the most developed countries, and we are not immunized against this. However, our death rate should be ideally calculated by the number of death cases over the number of recovered cases, rather than the number of death cases over the number of total cases. Although it may reflect the poor medical background of the patients, but it could also measure the efficacy of our health system. Fortunately, currently it is 21 over 1,316, 1.6%, and not 21 over 1,488, 1.4%. It is also important to note the dramatic effect on the small business sectors under the national lockdown system is much worse than that of the regional lockdown. By further locking down more specific areas on the most affected high-risk regions could easily release more pressure on the economy system. According to the New Zealand Government Stats website, the General Electoral Population, GDP, by New Zealand region in 2019, almost 20% of the gross annual domestic production, 60 billion out of 303.5, grows from the least affected regions by the virus, 7 out of 20 of the DHBs. The fourth stage of our plan includes opening borders and monitoring carefully. Much remains to be learned. The best evidence of whether the vaccines provide less protection against the new variants will be if we identify people who become infected with one of the variants after receiving 2 vaccine doses. Before that, we can learn from studies in the lab. Children, pregnant women, immune-compromised people, anti-vax, and people with severe allergies will minimize herd immunity. Children may be important transmitters of SARS-CoV-2, and vaccinating them with a vaccine that reduces transmission could be important in controlling the pandemic. 95% efficacy is not 100% efficacy. There have been some reports of fully vaccinated people still contracting COVID-19. Experts say these breakthrough cases are expected, but they should have more mild disease. We do not yet know how long protection lasts following vaccination, but it will be critically important to measure long-term protection, at least 2 years, in the phase 3 trials, and by following people who have been vaccinated outside of the trials. At this fourth stage of our proposal, We need to look at the rest of the world and find out where we stand and whether we can carry and spread COVID-19 after being vaccinated. Some studies on the topic appear to offer optimism, and scientists believe we will need top-up vaccines for the other hypervirulent variants. The chart on the left upper corner reveals how New Zealand governmental response has changed over time. It shows the Government Stringency Index, a composite measure of the strictness of policy responses to COVID-19 outbreaks. Meanwhile, the chart on the right side indicates that New Zealand is still behind the rest of the world in terms of starting time and progress. We hope by using the GIS strategy, the process with the vaccination rollover will be much faster. There is also a high need to learn from the other countries' experiences, such as Canada and Israel. As you can see by these two graphs, the number of those vaccinated is still very low in achieving global herd immunity. To date, although about 20% of the world population has received at least one dose of a COVID-19 vaccine, only less than 1% of people in low-income countries have received at least one dose. We will continue to use GIS mapping until we are absolutely safe. This means our program will not stop. According to some experts, this may take a few years. As resources are currently prioritised for the COVID-19 vaccine campaign, it is expected that it will inevitably affect other immunisation campaigns, such as the MMR. In addition, many people have deferred routine healthcare during the pandemic, including childhood immunisation against other infectious diseases. This has happened against a backdrop of already declining immunisation rates among children in general, and among Tamariki Māori and Pacific children in particular. On the other hand, closing the borders and restricting movement to stop COVID-19 transmission also reduced the spread of other infectious diseases. The big question is, when these controls are lifted, would the risk of serious childhood disease outbreaks, such as measles and pertussis, increase? Such questions could be answered by using predictions. Predictions using GIS is defined as spatially modeled interaction between geographic objects and phenomena to predict present or future spatial patterns, for changing conditions or trying to predict population behaviors, such as accessibility to health services. This type of analysis does sometimes extend to spatio-temporal domain. For example, modeling the impact of different scenarios of vaccination supply on the population reached and predict future coverage based on future location of vaccination delivery sites. More specifically, it can forecast the prognostic factors for the rapid spread of COVID-19 by using evolving models based on artificial intelligence procedures. It also consists of purpose maps that can compare the spread of the COVID-19 disease between the current period and the predicted period, providing the possibility to prepare appropriate actions and decisions regarding resource management. Currently, we don't think it's the right time to start the travel bubble between New Zealand and Australia, as we are not yet immunised. We need to keep social distancing from our neighbours until we are safe to do so. COVID-19 can only be eradicated by the vaccine. With the latest vaccine rate reported at 6.7 million a day, it will take an estimated 4.5 years to cover 75% of the world's population with a 2-dose vaccine. It will almost be impossible to vaccinate every person in the world at the same time. However, this can be achieved regionally. 70% of the transmission modes of the virus are from imported and imported related cases. This means that travel plays a major role in transmission. Locally acquired cases of an unknown source in New Zealand, which amounted to 4%, is the most dangerous group. During the time of alert level 4, on average, there was 46% less mobility across the country. In Wellington City, mobility was down 62%, more than anywhere else. In some rural districts, movement reduced by less than 20%. The risks on children in New Zealand who cannot be vaccinated for the time being. Children in poor communities are 3 times more likely than the average child to be sick, twice as likely to end up in hospital, and sudden unexpected death in infancy rates are more than 6 times higher for infants in the most disadvantaged areas of New Zealand. These harmful effects run into adulthood. In the end of June 2019, about 1 in 7 New Zealand children lived in households with less than 50% of the median equivalized disposable household income before housing costs are deducted. After housing costs have been deducted, the number of Māori children living in New Zealand in relative poverty rises to about 1 in 4 children, 69,100. The rate is the same for children in Pacific peoples households, 35,000 or 24.7%. These rates compare with about 17% for children, 124,300 in European households. Because there are only 31 million across the 14 countries in Australasia, it is wiser to be isolated from the rest of the globe, as we are able to be socially and economically independent until the pandemic dies off. This can only be achieved by vaccinating the whole population and keeping the regional borders closed. If there is anything common between these lovely kids and our political leader, it's the big smile. We hope that by February next year, we will be able to allow people such as athletes, international students, and family visitors to share life with us here in New Zealand. Based on the current pandemic situation, we feel that these people may need to be quarantined. However, opening the borders will provide a good support to the country's economy. Before we completely open the borders globally, we need to make sure we have enough resources available. This includes number of PPEs, masks, flu vaccines, COVID doctors, nurses, social workers, ICU beds, and essential workers. We should only allow tourist travel to occur under certain conditions, specified by our expert epidemiologists, such as people must be vaccinated, come from a low-risk country, and be tested prior to and on arrival. In addition, they should only be allowed to visit specific regions or limit their travel to either the South or North Island and areas where vaccination rates are high. This is so everyone is protected. In addition to all the conditions we stated, we recommend tourists be provided with a medical watch tracker given to them on arrival. This will be extremely beneficial to both New Zealand and the tourists' health. These medical watch trackers have been effectively used in other countries and will be highly beneficial at this stage for the following reasons. The medical watch tracker can monitor the vital signs of the symptomatic patient and warn medical staff when early warning scores are high. This data can be connected to St. John's directly. The medical watch bracelet can also discover new cases when temperature or other vital signs go up, as 80% of symptomatic cases have fever. The watch can also trace movement of the cases within the bubbles and warn them when they leave it. This can be limited by a centimeter accuracy using advanced technology. It also might be possible to trace more contacts by using the Bluetooth catching other contacts' phones. The fifth and final stage of our plan includes data analysis and SDSS in preparing for the future. We should be very careful when interpreting data from other countries, as our COVID-19 situation is different. We have almost no natural herd immunity, and therefore our protection will be completely from the vaccine. In addition, there will be a good percentage of the population who cannot, including children, pregnant women, people with severe allergies, and immune compromised, or do not want to be vaccinated. That's to say that we will never reach the immunity levels required for death prevention and severe impact on the health system. At this stage, where the supposed majority of the adult population have been vaccinated and international borders have been partially opened, we need to closely monitor how these implementations are impacting our health systems. We should also invest on researchers in this matter instead of blindly following the others. In addition, we can use both knowledge-based systems and spatial decision support systems to help us determine future health outcomes. As we mentioned at the beginning of the presentation, SDSS is interactive computer systems designed to support a user or a group of users in achieving a high effectiveness of decision-making while solving a semi-structured spatial decision problem. According to an article published by the Faculty of Geoinformation Science and Earth Observation University of Twente in the Netherlands in 2012, it has been concluded that there are 5 main concepts relevant for setting up an SDSS. The main concept we will focus on is the first one, spatial decision problems. Decision problem is defined as a situation where an individual or a group perceives a difference between a present state and a desired state, and where the individual or group has alternative course of actions available. The choice of action can have a significant effect on this perceived difference, and the individual or group is uncertain a priori as to which alternative should be selected. More specifically, SDSS answers 3 types of questions: descriptive questions regarding an event in the past, predictive questions regarding the future risk of the event at country level, and predictive questions regarding the future risk of the event at provincial level. In conjunction, knowledge-based systems is a tool to deliver intelligent decisions by utilizing data mining and artificial intelligence methods, by facilitating the use of data, models, and structured decision processes in decision making. It supports rather than replaces the user's decision-making skills. A typical knowledge-based decision support system includes 5 main components, namely data, model, knowledge base, interface engine, and user interface. Knowledge-based decision support systems have been extensively explored to support decision-making in all aspects of medicine because of the fact that medical conditions are highly diverse, fast-changing, and sometimes unpredictable. It uses statistical simulation models to provide required information for experts, who can then classify or cluster the information, or can search the parameter space to find an optimum control scenario. The outcome knowledge can then assist in identifying the future geotemporal occurrence of disease and potentially containment policy making. In addition, early warning systems, which is defined as timely surveillance systems that collect information on diseases with epidemic possibilities in order to plan intervention policies. So where should we concentrate our future efforts? As a fact, we know that the elderly are most at risk of dying from COVID-19. This might be partially explained by the fact that they are also most likely to have underlying health conditions such as cardiovascular disease, respiratory disease, and diabetes. These health conditions make it more difficult to recover from the COVID-19 infection. Our efforts shouldn't stop here. Rather, our extensive data should continue to be used elsewhere to tackle other health problems. This figure shows the percentage of COVID-19 cases with number of comorbidities by case severity, all age groups, and both sexes combined, all in Alberta. It is clear that the more comorbidities the patients have, the higher risk of ICU admission and therefore higher risk of death. New Zealand has always been vulnerable to devastation by natural forces, and there is a high need for more preventative measures for the future pandemics. The future collected data from our GIS, GPS, and the National COVID-19 Master Board workup on COVID-19 will be saved for our future needs. In addition, our system can also be applied to many other medical fields, including other infectious diseases in humans, such as measles. We should also bear in mind that we might need booster doses for other variants of COVID-19 in the future, and we need to be ready for an entire immunization program cycle, taking the available capacity into account. GIS also supports numerous other chronic disease prevention and control activities. With the number of chronic diseases, such as rheumatic fever, diabetes, and cardiovascular disease rising, GIS may provide a method in which healthcare professionals can systematically address where certain diseases are more likely to or already have become prevalent and begin proactively implementing preventative strategies or staffing healthcare professionals skilled in specific medical specialties. GIS can benefit a wide range of registry research questions and investigations. If a vaccine can be delivered equitably and universally, with the entire population able to access it, then so should all health services. Therefore, it is imperative that the Ministry of Health or the New Zealand Medical Council maintains a geographically referenced dataset that contains New Zealand grid reference coordinates of GP practices. The use of GIS in our health systems can be maintained by using the following strategies. This includes strengthening data sharing and partnership between entities producing this data, including but not limited to government, universities, and national statistic offices, exploring multi-sectorial use of geospatial data across government departments, ensuring mapping projects meet the needs of local managers to strengthen their participation in mapping projects, and integrating a GIS in curriculums in the schools of public health. It is time for a change, for a better future. I hope our message gets to the right people on the right time. And at least for now, the best defense against COVID-19 remains social distancing, mask wearing, and hand washing. We may be tired of this virus, but this virus is not tired of us. Kia kaha, New Zealand.